We're good?
Yes.
Or we're going. Okay. All right. Well, welcome to today's session. We're going to talk about two forms of treatment-resistant epilepsy for childhood, probably the ones that are most often talked about, although are not particularly very common, but they're very frequent visitors in the epilepsy clinic. So the objectives for today are to be able to recognize seizure types in Lennox Gastaut syndrome, be able to appreciate the spectrum of seizure severity in the genetic epilepsy syndromes, which is really a spectrum called GEFS plus, or genetic epilepsy with febrile seizures plus, and the more severe end of the spectrum, Dravet syndrome, and then to understand the comorbid learning and psychological challenges with treatment-resistant epilepsy. So let's go into our first case. So the first case is of a I should be in presentation mode. Hang on 1 second there. So a 17-year-old boy who has a history of infantile spasms, has intellectual disability, since the age of 3.5 years has had multiple seizure types. These include atypical absence, we'll explain this a little bit, atonic seizures, myoclonic seizures, and then typically has tonic seizures at night, although they can occur during the day, they're more often at night, and has failed multiple medications. So here's a video. Oops.
A type of generalized symptomatic epilepsy, very difficult to treat, and having a relative.
So that is an example of a person having most likely an atonic seizure, the way he sort of leaned forward. Certainly there are two types of drops attacks. It could be that he was stiff all over and fell to the ground. That would be a tonic seizure. And because you're so stiff, you can't support your weight and you'll fall to the ground. This one kind of gives me the sense that he was leaning forward in what we call an atonic. The atonics tend to be very brief, and they tend to come in clusters and repeat themselves. Many times people think of the person who has Lennox Gastaut like this young man who's wearing a helmet, and my gut is probably in some type of special school for children who have intellectual disabilities. So let's talk a little bit more about Lennox Gastaut. So the typical onset is between 2 and 5 years, and it affects males more than it does females. It represents 10% of childhood epilepsies. And it really consists of a triad where you see multiple seizure types. The tonic are those stiffening ones all over, mostly nocturnal. Atonic, the drop attacks that tend to cluster. Atypical absence, meaning there's an absence seizure, and what makes it atypical is really the EEG and what it correlates with. So instead of a childhood absence epilepsy, that's a typical absence seizure. You'll see 3 cycles per second or 3 hertz spike waves. With atypical absence, it's a slow spike wave pattern, usually between 1.5 and 2.5 hertz. And they can also have tonic-clonic seizures. Not to say that they can't have focal seizures, but those are the key types, and probably a little bit of myoclonus. They commonly have an intellectual disability, although it's not a requirement, but I would say over 98% have some type of intellectual disability. And then the EEG, it can be both the ictal and the interictal, where we see this slow spike wave. For the etiology, 2/3 is symptomatic and 1/3 we really don't know. We call those cryptogenic, meaning we think there's some underlying pathology, but we just don't know what it is. And as I mentioned, a small number can have a normal intelligence. I have yet to meet somebody who has truly normal intelligence, or let's say completely normal cognition, although there are cases reported in the literature. I don't know, Dr. Jones, have you ever seen anyone with completely normal intelligence? There's usually at least some type of cognitive dysfunction that's pretty severe. They just might have an IQ slightly higher than 70 and don't meet the criteria. This is a typical EEG of a person who has Lennox Gastaut syndrome. And just to orient you, the most important thing is not necessarily where we are in the brain, but what you can see is these darker lines represent a second. And so when we're looking at EEGs, one of the things we do is say, how frequent are those waves? And what you can see is there are two waves fitting in that big box. So this is slow spike wave. The next EEG, you see a lot of really fast, spiky looking lines, and that's really what it is. One word for it is paroxysmal fast. And this can correlate with a seizure. It can also be seen in between seizures. If this were a seizure, the type of seizure I would be thinking about would be a tonic seizure. So this kind of looks like could have been happening, hard to say on the background whether it's sleep or not, but maybe if this were sleep, this could be potentially, sometimes there's subclinical seizures happening as well. In terms of treatment, as we mentioned, these are a group of treatment-resistant epilepsies. We'll usually pick something broad spectrum, meaning a medicine that can work for many different seizure types, as opposed to sometimes we pick medicines that have a more restricted application, because we know these are people who have multiple seizure types. Valproic acid is still a gold standard, so using divalproex or valproic acid is very common. And it's still sort of a mainstay, I think, for this particular syndrome. Bamzel or rufinamide is an option. Onfi or clobazam is another option, and then felbamate. There are many others that we use, but those are pretty typical. Any thoughts about that? And then it's not uncommon for someone like this to have tried 10 medicines, and now you're working on the 11th. And so they have a large history of failed because of lack of improvement, and failed sometimes because of toxicity, or failed because of side effects. And their comorbidities really play a role here, I think, in terms of our treatments. So for example, if this is a very sedentary young person and they're already overweight and now they're 17 and you're worried about them having later risks for other health problems as an adult, you might be concerned about valproic acid. You might be concerned that it's adding to their obesity. Or maybe it's a young adult who has behavioral problems. Felbamate sometimes can activate some of those underlying behavioral problems, make them more impulsive or more agitated. And so we have to really think through what's the best medication combination. And sometimes, even though they can be very efficacious, we have to pull back a little bit and use lower doses just so they can be tolerated. Dietary therapy is something we turn to with all of our treatment-resistant epilepsies. And there are many of these. At some point in the future, I hope that we'll talk about dietary therapies for seizures. But the most common one, and probably the one you're most familiar with, is the ketogenic diet, which is really almost like eating pure fat. There's just enough protein in that diet for growth to make sure that you have an adequate amount of protein. And there's almost no carbohydrate. Really, the carbohydrate that comes in is sometimes in the form of pills or just enough to make it palatable. And then my colleague Renat Jonas can speak more to, I think, surgery.
Yeah, so children with Lennox Gastaut, like we said, many of them are symptomatic. Sometimes it's genetic, but sometimes it might be structural. And if there is identified structural abnormality that is focal, let's say one-sided, and in an area that can be easily resected without causing too many deficits, a resective surgery might be a very good option for these children. On the other hand, children who have a lot of drop seizures, many times these drop seizures are actually starting in one area of the brain. So it's a focal seizure that kind of generalizes to the other side, and you have the drop only because it generalizes. A corpus callosotomy is a procedure where you cannot actually resect part of the brain because there is not an identifiable area that is malformed. However, you can a little bit divide the corpus callosum to prevent the generalization of the focal seizure from one hemisphere to the other. A corpus callosotomy is more of a palliative kind of a surgery because it does not prevent the seizures, it just causes them to be, rather than generalized seizures where you drop, more focal seizures. So the patient might just present with what we call a complex partial seizure, maybe some shaking on one side, maybe staring, but would not have the typical drop.
So it's really about quality of life, right?
Quality of
We're
life,
really
yeah.
trying to make them less dangerous. Is really
Right.
why we do the surgery as opposed to seizure freedom.
Yes. Another two kind of devices that we nowadays use. So the more common one is a vagal nerve stimulator, where it's actually a device that you implant a pacemaker in the chest area, and it sends impulses to the vagus nerve. This is a not on-demand device, which means that it's just sending pulses that we can adjust the frequency, we can adjust the strength of them into the vagus nerve, and we're not really 100% sure why it helps. However, it is a seizure suppressant. It's also quite good for mood, and it's a treatment sometimes from depression. And we hear in children with Lennox Gastaut who have behavioral issues and mood issues that actually the vagal nerve stimulator was actually helping not just with their seizures, but also with their behavior and mood. NeuroPace is the newest device that we have now. It is meanwhile approved only for adults, so 18 and above. And the advantage of the NeuroPace is that you can implant, you can have actually two seizure focuses. So let's say in a resective surgery, you need to have only one seizure focus, let's say on the right hemisphere or the left hemisphere. With NeuroPace, you can have actually two seizure focuses, which would be one in the right hemisphere, let's say, and one in the left hemisphere. You implant electrodes directly on the surface of the brain and record the seizure pattern. And it is known that before you actually have a seizure, there is an increase in the amount and the frequency of the epileptiform discharges before the seizure. The NeuroPace learns your own seizure pattern and gives an on-demand impulse. So only when there is so and so many epileptiform discharges arising from a specific area, then the NeuroPace is giving an impulse to try and stop these seizures. It has about the same efficacy like the VNS. All of them have about the same efficacy like seizure medication, which is about 50 to 60%.
You might use the vagal nerve stimulator if you don't have a focus and it's multifocal or it seems to be more generalized, and maybe NeuroPace if you actually have a lesion that's in an area that you can't resect because there's something important, something high functioning there. All right. So on to the next case. So you might imagine the next syndrome. So there's a 3-year-old boy who had been born after a normal pregnancy and a normal delivery. And before the age of 1 has 3 complex febrile seizures. And by complex, what we mean is they were long and they were one-sided as opposed to the whole body shook or focal. Now at age 3 is presenting with myoclonic seizures, generalized tonic-clonic seizures, and complex partial seizures, what we call now focal seizures with altered awareness. And these seem to be worse when this child is ill. There's been a developmental regression, had been doing well, and now we're starting to see a change. And the developmental regression is often cognitive, language, and to some degree motor. We'll show you that in a minute. So we're talking about actually a spectrum of epilepsies, and we call this the genetic epilepsy with febrile seizures plus, all the way to the more severe form, which is called severe myoclonic epilepsy of infancy and goes by the name Dravet. So GEFS plus all the way to the spectrum of Dravet. So as we know, many children have febrile seizures, and these can be genetically based, and they only have febrile seizures. But they may have other syndromes, all caused by similar genes. One is febrile seizures plus absences. So that means absences without fever, or febrile seizures and they get myoclonic seizures, or they can have febrile seizures and drops or atonic seizures. There can be febrile seizures and partial epilepsy. And then there's a form called myoclonic astatic epilepsy, which can be caused by a similar spectrum. And then lastly, we'll talk about this case, which is severe myoclonic epilepsy of infancy or Dravet. Did you have anything more you wanted to say about that? So a little bit more on the spectrum. So as we talked about, it's a spectrum of diseases. And what can happen is within the same family, you may have somebody who exclusively has febrile seizures and somebody who has the more severe form. So you don't necessarily have to all have the same presentation.
And I have an interesting family where the grandfather had febrile seizures. The mom had febrile seizures and mild epilepsy until she was 18 years old and she outgrew it. And the daughter has Dravet syndrome, which means she has multiple seizure types, started very early on, and has some delays going on with it.
It's predominantly a condition of the first decade, and the more severe end tends to present before 1 year of age. So febrile seizures, we say, are common. But I think for Renat and I, if I hear of a child less than 1, especially if they have hemiclonic, so shaking on one side of the body, I'm going to be a little bit more worried. It would probably be the kid I would like to see in the epilepsy clinic. Unlike any other kid who has febrile seizures after 1, I would probably want to see those kids because we're more concerned about a genetic syndrome that may have a longer course. It's usually recognized because it has dominant pedigrees, and not everybody in the family will be affected. That's not to say that all of them are inherited. There are children, we'll talk about in a minute, where they actually have de novo mutations, so nobody in the family is affected. And we tend to see generalized spike wave on their EEGs. There's an evolution with the children who have the severe end of the spectrum, the Dravet or the severe myoclonic epilepsy. Pretty rare condition, though we have a fair number. We're a little biased because we're a tertiary epilepsy center, but it's not uncommon to us. And like I said, it doesn't take many of these children to really keep us busy because they tend to be very sick. So it starts often, as we talked about, with the febrile seizure, usually hemiclonic. And the EEG may be unremarkable. In fact, I have a child that I follow that was very similar. I had hoped this was just going to be febrile seizures. And then after age 1, the child started to have some other seizure types and had seizures without fever, some that came out with vaccines, some that came out with just being too warm, too hot. And now the EEG started to show some abnormalities. Development may plateau, and I think that plateau is more likely the more severe the seizures, the more frequent the seizures, the harder it is to control. And then over time, what we start to see is a cognitive and behavioral regression. And in the more severe ends of the spectrum, we actually see it impact motor, where children will start to walk on their toes because they have upper motor neuron signs. They may be ataxic. And it's always hard to say, well, how much of that is the medications, because they require multiple meds, and how much is the underlying encephalopathy created by the epilepsy. And then we start to see that maybe this kid is actually becoming intellectually disabled. It's hard to call somebody intellectually disabled before 5. We'll have a concern about cognitive delays, but it's around kindergarten, first grade that we can start to say something more meaningful about intellect.
Well, that's an interesting point about the ataxia. So the genetic mutation or the genetic abnormality that we're going to talk about is usually in the sodium channel, and usually we see it in the neurons. They are also present in the Purkinje cells of the cerebellum. And that's why many times these children develop at the end some cerebellar findings with ataxia.
Yeah, I have one gal that I followed from the time she was probably 2 or 3. She came to me after having the earlier course when the seizures became harder to treat. And she was of completely normal intellect. In fact, we checked her at age 3, had a neuropsych profile, and it was thought she was going to have superior intelligence. And then when she got to mid-childhood, she has an IQ somewhere around 55. Similarly, her motor skills were excellent and was very coordinated, and now is very ataxic, tremorous with long track signs. And just a point that Dr. Jonas put on the slide for us to remember is that obviously when you have a child who has treatment-resistant epilepsy, they do have a higher mortality rate. And in another talk, we're going to talk about sudden unexpected death associated with epilepsy, but both Dravet syndrome and Lennox Gastaut have a higher rate of SUDEP. So here's a video that we're not put together. And we're going to see this little boy at different ages with different types. So maybe those first two jerks were myoclonic. We were discussing the video. This seems to be left arm sort of focal clonic activity, what we call hemiclonic. Sometimes we've seen kids where the face is involved. Now you can see that it's hemiclonic. I just think about this. The left arm and the left leg are jerking. And there was a little head drop there. There again.
Yeah.
And sometimes we'll see that there's an absence associated with that. And generalized spike waves on EEG is a little head drop. You can start to see that there's multiple seizure types so far. We've seen myoclonic, hemiclonic, and maybe a little atonic component. Here is the same child at a younger age. You can see the eye deviation. There's the nystagmoid movements to the left. Here he is in the high chair. And there's a little myoclonus.
Even with that little eyelid.
Yeah, and there may be a component of absence. The eyes went up. It's hard to know if there's also an alteration of awareness. This is all in the same child. This is not one of our patients, but a family had posted this. And we thought it was actually a very accurate representation of the syndrome. Again, eye deviation, example of focal seizures. And again, he's having a focal seizure right now. I don't know if you're appreciating his eyes are deviated to the right. He looks like he's just looking off in one direction. He's a little unsteady. Here he is again, same focal eye deviation off to the right. Seems to maybe be alerting there, but the eyes are still deviating. A little jerk of the head backwards and some little myoclonus. Here he is, much older, same boy.
Tonic.
Right, the eyes are wide. And as the seizures evolve, it's very hard for families because they seem so much scarier to them as they get older. Seems to have a little clonic component to this one. This is actually quite a long video, so just in the interest of time, I'm going to stop it because I think we've seen quite a few seizure types. So in just the example we saw almost all of these, I think, generalized tonic-clonic seizures, hemiclonic, focal seizures. They may have a lot of autonomic symptoms, like flushing would be an example of one of the things you might see. Myoclonic, atypical absence. They're less likely to have tonic seizures. Triggers, this is kind of unique. So it's not just fever. We're used to fever and illness lowering seizure threshold for all of our patients, whether they're in the treatment-resistant category or in the relatively easy-to-treat category. But what's unusual and is often a real sort of flag, I think, to both of us is that heat. So I'm thinking of a patient of Dr. Jonas's who was a family who didn't have air conditioning in the summer. Was very difficult for them. They had lots of admissions.
Yes. Just environmental heat. These children should not take hot baths. You know, you have to make sure that the water is really just lukewarm, because just sitting in a hot bath can trigger a seizure.
So anytime the environmental heat goes up, that can be a potential trigger for these children, and just feels so contrary to what we usually think about for our children having a nice warm bath. And then vaccination. One of my little guys, we actually gave his vaccine in hospital in the ICU, and it was still a challenging event for him. The EEG, as we talked about, can initially be normal, and so we usually can be relatively optimistic in the beginning. And then as we see the evolution of the epilepsy, we begin to have to talk about a more treatment-resistant and a more challenging prognosis, I think, for the child. The EEG can be multifocal, it can be generalized, you can see spikes, you see polyspikes, they tend to have a more posterior predominance, and they may have photosensitivity. sorry, a few more slides. And then the MRI is normal with the thought that these are genetically based. So the genetics of Dravet, or severe myoclonic epilepsy of infancy, most of them are sodium channel, the SCN1A mutations, and they can either be a truncation, so a shortened protein, or a missense. It tends to encode for the alpha subunit of the voltage-gated sodium channel, and that can be a gain of function where it's hyperactive or there's a loss of function, and it resides on 2q. 5% of these cases are familial and 95% are de novo. And so you may not have a family history at all. So you have to go by the child's history to think about whether you want to get genetic testing. We talked about it being a spectrum from very mild to more severe. And it can involve a whole host of other genes. It does not have to be this SCN1A. We have kids who have a different sodium channel mutation, SCN1B or SCN2A. It can be on the GABA genes. So these are your genes that are help to make the brain less excitatory or inhibitory. And then there's a unique syndrome, PCDH19, protocateherin 19, which used to be called EFMR, but now it's more appropriate to say epilepsy in females with intellectual disability. There are some males, they're usually mosaics, however, and there's a real spectrum within that, but they similarly present before 1 year of age. So just looking at from mild to severe end, the missense mutations code for an abnormal protein, whereas the nonsense mutations create a stop codon and then you don't have the protein. So you can understand the severity. It's these, the nonsense, that you usually don't inherit. Those are usually the de novo mutations. So treatment, again, it looks really familiar to what we talked about with Lennox Gastaut, that we'll use broad spectrum medicines, valproic acid, topiramate, clobazam. But what's unique to these is because 80% are associated with the sodium channel, you have to avoid the sodium channel drugs. And there are more of them than what we've listed here. But lamotrigine is a common one, carbamazepine, oxcarbazepine, or phenytoin. These should really be avoided. Stiripentol is a medicine we cannot get in the United States. It's used in Europe. And the idea is that it enhances GABAergic transmission, so it makes the inhibitory neurons work better. And it increases levels of other AEDs. So for example, if you give it with clobazam, commonly you'll see a higher clobazam level. You want to avoid triggers, heat, do the best to keep the child as well as possible. Unfortunately, giving antipyretics, it's not clear that really is helpful for a child with febrile seizures, never mind a child with Dravet syndrome. But obviously being proactive, keeping the temperature down. I usually recommend my patients have spray bottles around, make sure the child gets into the shade. Just have to think wisely about outings during the hot weather. And then the ketogenic diet is used just like it is for Lennox Gastaut. And there's a lot in the media, a lot in the literature about the use of cannabidiol. Again, I think this should be a talk for another learning collaborative. I'm not sure how many questions you get about the use of medical marijuana, but this is a very specific compound within marijuana that is not psychoactive. So when children get this, they do not act high. And there's some evidence that it can be helpful, both for Lennox Gastaut as well for Dravet. But it got a lot of media attention in a documentary that was on CNN with Sanjay Gupta, and so maybe some of you have seen that. So that ends today's sort of didactic portion.